Hello everyone, good evening, and welcome to tonight's webinar with Dr. Luca de Stavola, that he is already here with us. Ciao, Luca.
Ciao, ciao Francesca. Hello, everybody.
Thanks everyone to joining this webinar tonight. Despite it is a little bit late, we are very happy to have you all with us. But in the meantime that we wait other participants to let in and to start the webinar, I would like to give you some instructions and directions for tonight. Probably you already noticed that your microphone has been put on the mute mode because we would like not to interrupt Dr. Luca during his lecture, but we highly invite you to write any questions in the chat box of this webinar, of this Zoom platform, because at the end we will leave like 10 minutes to answer all the questions and give you and let Luca reply to each of them. And additionally, I would also like to let you know that if any of the strategies and the tips that Luca will show you tonight, if any of these will be of your interest and would like to deepen each of them, we highly invite you to our course that is on October, and more especially on October from the 21 to 23 in Padova. If you scan this QR code, you can see all the info and the program, but we have also our mobile phone and our email. So in case you would like to know more from us, just please take a picture to this slide. So, Lucas, shall we start?
Yeah, sure. That's great.
I leave you the floor, I leave you the screen, and I wish everyone a good listening. Enjoy the webinar.
Thank you. Thank you, Francesca. And just let me know if everything is fine, if you see something or not.
Yeah.
Yeah, fantastic. So welcome to this webinar and virtually welcome also to Padova, uh, our beautiful city where our academy was born and when it's growing. And you know that Padova is northeast of Italy, is close to Venice, and it's one of the oldest university that we have in Europe, particularly for medical science. And actually, the anatomy, what we know as anatomical study, as modern anatomy, has been developed in Padova for the first time. And since we are talking about anatomy, because is an important point when we are talking about bone atrophy, is anatomy is one of the aspects that we are going to analyze to understand which is the strategy behind the bone augmentation. So, doing a bone augmentation, for sure, we have to understand why we are doing that, because it's obvious that having other options or alternative options every time we should consider them to simplify the treatment and to go easier and faster to the target. So the first point will be why we are still talking about bone augmentation, or why bone augmentation is a hot topic, particularly vertical. How we would like to do, it means which are the principles that are linked to the bone augmentation. Because if we know how the bone augmentation is going to happen, then we can understand what we should do to obtain the bone augmentation in a predictable and repetitive way in a daily work. So starting why we do vertical bone augmentation or bone augmentation in general is that usually because we have no plan B. We have situation that due to maybe trauma or due to periimplantitis had generate bone deficiency where the alveolar crest is not there anymore. But we are also in that scenario where patients are still having teeth, and the teeth cannot be extracted just to place implants or to have bone available to place implants. And the patient is asking actually for solve a local problem and obtaining a result which is similar to the dentition that is there. So, and usually these are the patients where I'm working on and I'm looking for performing a bone augmentation. And usually these type of deficiency are coming as a problem or as a problematic scenario because previously there were implants in that position. So the pathology of perimplantitis, particularly narrow anatomy, is ending up with a vertical defect in the majority of the cases. And for sure, what we have to think or to expect is to have predictability on what we are doing because the patient is asking for that, is coming for the predictability of a treatment, is not coming for a technique that we may use on a specific scenario. And predictability means that we are starting with an atrophy. We are able to build up the bone back with a defined approach. And we are going to obtain a good result, and that good result remains stable among the years. For example, this 12 years on the CBCT, 15 years after the treatment. So we're going to have stability of what we have obtained. And this is still 18 years. And 18 years with the also show with the stability of the soft tissue and the supracrestal tissue that remains exactly at 3.6 millimeter from the bone, and clinical appearance at 19 years after the treatment. Or this case where the implants are placed actually where there is no bone, and using again one of the options that we have in terms of bone augmentation, we are able to reconstruct the anatomy of the patient. And the anatomy is important to be recognized in terms of dimension, that not all the anatomy has the same characteristic. And this is then the result after the bone augmentation and the reestablishment of a function of and a natural appearance of the implant, of the crown supported by the implant. And this is before, after 6 years. Now, this case has 10 years follow up, even if I'm not showing you the x-rays, but it's 10 years that follow up for this case. Or this case, again, due to perimplantitis, localized vertical defect, 7 millimeters. And this is the situation many, many years after, 15 years, with a great result and great stability of that result. So for sure, the patient is looking for this, is looking for the predictability. And I'm not bringing any flag in terms of bone augmentation technique. I'm using a lot of approaches. I'm using GBR, I'm using PTFE membranes, I'm using sometimes meshes, I'm using Curie approach, obviously. But the target is every time is how to get the predictability, how to solve the problem of the patient in the most effective way, and time, treatment time that is not long, that is not taking more than 1 year, usually 9 months to the loading. So treatment that are relative fast and allowed us to solve the problem of the patient and obtain stability of that result. So sometimes we are even mixing techniques together to obtain that stability. And obviously, as you're going to appreciate, it's not just a combination of bone, a good result, but it's a combination of many factors. Not just the bone, but also the supracrestal environment, the right soft tissue height to recreate the biological width and stabilizing in that way the bone. So it's important that we are thinking on the long-term result, and we are not fixed to one specific approach because we can get advantages from different approaches. And these approaches, when they are used in the perfect scenario, they are going to give our best or are going to give their best in terms of predictability. And this is a 5 years result after the vertical bone augmentation. and 7 years on a CBCT analysis that again shows us how nice is the bone, how the integration of the graft into the recipient site and the distance between the starting point in terms of bone shape and the tissue after 7 years after the treatment and the smile line compared to the starting situation. And this is an 8 years control. So 8 years of function after vertical bone augmentation, and the bone is perfect because we respect the biological width, we respect the anatomy. We rebuild the anatomy in respect to the patient's own anatomy. So it's obvious that, again, if I have to think which approach is better, we don't have big data, we don't have great data from the literature. So it means that both from GBR and block, we have not too much data long term. So it's difficult to say we are supposed to use one approach compared to the other. So, but we have for sure some fixed point when we try to compare approaches, which is the biological background that we have in all these approaches. And the key point is that all the techniques are supposed to support the biology because the biology behind the bone augmentation is just one. So it doesn't matter which type of approach you're using. Our body will react and forming bone through an intramembranous ossification process. So first of all, we need a blood clot. And the blood clot during the inflammatory reaction will be turned into a provisional matrix. And this provisional matrix will represent the structure for a direct ossification, turning into a new bone through woven bone formation. And then this woven bone will be replaced by lamellar bone, which is a mature bone obtained by the turnover of the bone structure. So the key point is for sure to understand which are those elements determining how our body is moving from a provisional matrix to a woven bone formation. Because actually the surgery is supposed to create exactly that environment where this is going to happen in a very, very predictable way. And we have to consider that we have three pillars on that: vascularization, inductive factors, bone related, and mechanical stability, which is the best scenario. And there are three biological pillars that must be there to obtain the final result. Particularly, vascularization is important. So bone regeneration is a vascular process because through the vessels, the blood cells, the perivascular cells are coming to regenerate the area, recreating the provisional matrix and then the ossification. So vascularization is extremely important. That's why also soft tissue management is extremely important to this topic to protect and the graft and obtain a primary wound healing. That is a prerequisite for having then a good result and good vascular support. So, and then besides this, or on a side of these three pillars, we have also the defect geometry, which is impacting the process by the characteristic of the deficiency. And the deficiency is characterized by the number of the walls, the wall distance, and the mechanical protection. Because obviously the bone is growing from the walls of the existing defect. So that's why it's important to analyze from where the bone is going to grow. Because we know that from this study from Schenk milestone for the GBR, bone formation began on exposed surface of the defect towards the center of that. So many walls are representing a good starting point or a good predictability point for the regeneration. And then obviously the distance, because the distance, as we know, is impacting the capability of the defect to regenerate the bone inside. And unluckily, the distance has a very negative impact with the growth of the distance between the walls. And as soon as we are growing more than 10 millimeters from one to the other wall, then the capability of the defect starts to be decreased. And this we know in the sinus, but has been also very well demonstrated by Stucky studies on not just sinus lifting, but also internal sinus lifting. And then obviously mechanical protection, because number of walls and wall distance has an impact on the mechanical protection, and more the graft is protected by the environment, better it is for the ossification process. And but unluckily, we have to remember that we are working in the mouth, and we have a lot of muscle activity working against our graft, from the tongue, from the floor of the mouth, from the buccinator muscle, the lip muscles. So all muscles start interfering with the stability of the graft, and the stability of the graft has a negative impact on the ossification process. So as we know, for example, on the strain resistance, that is supposed not to go more than 30%. Otherwise, osseointegration of a graft or an implant is not going to happen. So how we can support the biological process, particularly in difficult scenarios with autogenous bone, because autogenous bone is helping the process, not changing the process, but is helping the process in terms that is autogenous bone is working like extra walls of the defect, in biologically speaking, supporting the bone formation. And we know that from osseointegration process, we know in sinus lifting compared to other materials like homologous or synthetic or bovine bone, that autogenous is working much better in de novo bone formation. And the quality of the tissue that is going to be regenerated is much better compared to those graft that, or those area where the graft is not properly boosted with autogenous bone. So autogenous bone is not just a matter of being invasive or being brave on doing that or being smarter, or it's just the biological needs when the distances between the walls starts to grow more than 10 millimeters from each other. So, and then we have also asked to ask ourselves why we are doing a bone augmentation and why we are doing that change of shape eventually, because we may have different target. We may need more bone for implant placement, so new vital bone for osseointegration, or we may need just a volume, just for a shape, just to mimicking the presence of a root, for example, or both scenarios, meaning vital bone and volume. So really depends on the target, but this is important to define the target, because it's obvious that if I need to have vital bone, I need to support the biological process. If I have to create a volume, I need to track the physiological bone turnover. It means that I need to do something that is non natural for that crest, but I want to have that shape and maintain that shape on the long term. So if I'm going to place an implant which is actually can be placed completely into the bone, and we are going just to reshape the crest, or maybe just covering some threads of that implant, but actually we are just making a contour augmentation in a scenario like this, then it's obvious that, for example, autogenous bone is not the best material ever, but we have to think about non-resorbable material, because are giving us a much better result and stability, because usually by a contour augmentation, we are going outside the envelope of that genetic structure for the patient. And you see before and after, and 1 year after the treatment, how nice is the soft tissue and the stability of the bone around the implant. So why it's important to work with no resorbable material? Because it's obvious that if I'm using a resorbable material in outside the envelope, this material will undergo or will be under the pressure of the muscle activity, and this may bring a change of shape due to a mechanotransduction process. So it's obvious that this type of bone augmentation is absolutely with no future, because the majority of the graft will be through a mechanotransduction process completely resorbed. And usually this is going to happen in the first 3 years. So what about the use of autogenous bone and the bone harvesting process? because we are thinking every time that harvesting bone is something that is bringing or impacting negatively on the experience of the patient. But this paper uh, from Daniel Toma, which is a randomized controlled trial, is showing us that actually harvesting the bone from the retromolar area is not impacting to the postoperative experience of the patient in terms of pain, in terms of swelling, in terms of willingness to repeat the treatment by the patient. So then actually this is also my experience. I mean, if we're working on the retromolar area, this is not going to be an issue for the patient on the post-op. Different thing if we're working on the chin, because if we're working on the chin, this is going to have a big impact on the postoperative uh, um, pain of the patient. So that's why usually chin is not used anymore, and we try to stay away from the chin. It's much better to harvest eventually from both sides in the retromolar area instead of working on the chin. But the quality in these studies shows clearly that autogenous bone is giving a better result, much better result, more than the double compared to the use of BMP2 and xenograft. And this matters for the predictability. So if the target is to be predictable, using autogenous bone in critical size defect is a point to have that predictability. So the study concluded in an equal post-op discomfort, but more bone in autogenous bone group. So every time we have a critical scenario, then we may use tree fine, we can use a block. It doesn't really matter which is the size of the bone you are harvesting from that area, because there is no vascularization. There is no terminal branches of the nerve in that area. So it's not impacting the amount of bone you're harvesting from there. So, and for sure, one point that we have to consider in the defect is also the vertical growth, because we have data that showing us that if I'm growing till 5 millimeters, GBR is extremely predictable. This is a study from Istvan Urban. And then it starts to be less predictable in terms of gain if I'm going from 5 to 8 and obviously more than 8. So due to this, it's usually suggested not to place the implant together with a vertical bone augmentation. And what I'm doing, based also on this paper, is that everything that is less than 5 millimeters, I'm going to treat usually with a GBR approach. And everything that is bigger than 5 is treated by Curie approach. So why? Because it's obvious that if I can do bone augmentation and implant placement together for the patient is one surgery, and I need to wait just 6 months. And at 6 months, I can do the remove the membrane, do a connective tissue graft, and 1 month later we can go to loading. And working this way is extremely predictable. It's working very well. And for the patient is a 2 surgeries treatment and 7 months to loading. So it's a relative short time frame, and the result is extremely nice in terms of soft tissue stability and bone stability that has been gained. But if it's more than 5, then Curie approach starts to be faster despite the same number of surgeries that are needed. So first of all is bone augmentation, 4 months later implant placement, and together nowadays with soft tissue management and augmentation. And the third surgery is the implant second stage, which is usually a small, very small incision on the head of the implant. It means that is in 8 months to loading for the patient. So what we do to do the bone augmentation, particularly with the Curie's approach for critical size vertical defect from a hard tissue point of view. From a hard tissue point of view, we work first of all on harvesting the bone, and we know from literature that this is a well-tolerated approach with a low complications rate reported from the literature. But one of these complications is for sure related to the nerve exposition, which is not impacting actually the functionality of the nerve, but obviously is impacting the surgeon in terms of stress related to the surgery. And I was used to work freehand with the microsaw approach, with using anatomical landmark to try to be safe and effective on the same time. But it's obvious that this is a speculation regarding the real position of the anatomical structure. And sometimes what is going to happen is to find the balance between what I need to harvest and the safeness process. What we are getting out from the retromolar area is not exactly the size expected, but can be less than what we would like to have. And nowadays, for sure, with three-dimensional analysis, we can understand everything regarding the external oblique line of a specific patient. But then the problem is how I can transfer this into the surgical field, knowing that when we are approaching the ramus, the alveolar nerve can be really very close to the working area, so less than 2 millimeters in 26% of the cases that we treated in a 50 cases, 50 patients analyzed. So that's why when we're working freehand, all the approaches are talking about being very superficial, don't go into the depth, and then generate the fracture in the depth to luxate the block. So the concept is stay cranial and actually be brave, because you're not really know what you're doing. And what can happen is the alveolar nerve exposition, as reported by Curie in 7% of the cases. And again, this is not really a problem for the nerve. It's for sure a problem for the surgeon. It's an uncomfortable situation, particularly when you are thinking to repeat the approach on the next patient. But the thing that really changed my mind happened some years ago, when the fracture line ran lingual to the nerve, and was really tough to take out the block and replacing back the nerve, that luckily had no impact on the functionality, but for sure had an impact on my self-confidence on doing this type of approach. And that's why we started in 2011 thinking about this together with Andrea Fincato. And we developed the guided approach, the guided bone harvesting approach, which is an approach that we published in 2015 and 2017, but has been patented in 2013. Actually, is an approach that allowed us to define all the osteotomy lines in advance, meaning that we can decide how to cut the bone three-dimensionally, keep the right distance to the nerve. And there is a software right now, which is a RIA Guide software together with a SafeCut plugin, that allow to do this, which is a medical device, FDA approved and CE approved. So it's born and dedicated to do this, which is um, which is important from a medical perspective point of view, because this is a medical device that allowed us to do this. Is important also from insurance perspective. And what is going to happen? That we can generate a three-dimensional ruler, which is the guide, the SafeCut guide, that allowed us to work with a piezoelectric tool, and is a sort of really guidance three-dimensional ruler for the piezoelectric tool, that is going to perform all the osteotomy in a super nice control way, because it's like to work with a ruler and a pen on drawing a line, but this is a three-dimensional work situation. So full control, no problem to interfere with the nerve, because all the osteotomy are planned to be cranial to the nerve, even if we're moving more distal into the ramus. So it's obvious that we have a lot of potential benefits on this. We have safeness, we have quantity, bone quantity, and user friendly, because we downgrade completely, which is the skill related or the experience that a surgeon has to do to perform the surgery. Guide positioning is extremely easy, thanks particularly for the tooth reference points. design that allowed us to place the guide very fast into the donor site. And there is a huge simplification on the approach because we don't have to invent anything during this. We don't need to cross the information of the diagnosis and surgery in our mind because everything is already written in the surgical guide. The piezoelectric tool is faced again flat to the interface of the guide, and this allowed us to perform perfectly the osteotomy three-dimensionally. And in the apical direction, there is no way to go more apical than expected because the guide is a sort of barrier, physical barrier, not to migrate more apical. So we remain cranial to the nerve anytime. And we published a study in 2022 that reported a great accuracy in terms of planning and performance. So something that freehand is almost impossible to be obtained because the osteotomy are really exactly where we would like to have. And this allowed us to rethink completely the strategy on the bone augmentation because we can go easily into the ramus to reconstruct huge vertical defect. We may have a pre-visualization of the bone augmentation that we want to do so that we are approaching the surgery by knowing perfectly what we are going to do on the surgical field, starting by the harvesting uh, with a very confidence on performing the osteotomy because we know where we are, we know the direction, we know thanks to the surgical plan how to perform those osteotomy into the depth, and will be extremely easy once the osteotomy has been three-dimensionally performed, vertical, apical, and distal, to luxate the block and having that piece of bone available for the bone reconstruction. So, and you see also the accuracy of the guide into the donor site. So flaps are elongated and block is stabilized in the anatomy, so in the envelope. First the buccal block, mesial and distal, and then through the buccal, we are going to stabilize the lingual, which is freehand, obviously quite challenging to be performed, but we are going to see also the solution for this problem coming from the digital field. This is the space that has been generated in the anatomy with the autogenous bone particles placed in between. So this is the post-op CBCT that show us the target in anatomy of the bone augmentation, and this is the bone 4 months later. So very few months to have the right bone, a good bone to place the implants. Standard implants are placed. Again, since it's a narrow anatomy, a relining approach will be performed to protect this environment and recreate the right structure. So 4 months later, we can go to the implant second stage, and this is the bone. It's an amazing amount of bone with the autogenous bone vertical augmentation and the relining later on. And you may see the fractured implant at the base of the defect at the beginning of the treatment and where it is that fractured implant. Very low and deep at the old base of the defect. So what we added in the last 5, 6 years, for sure, the guided block management, meaning the fact that knowing the shape of the block, we can divide the block into two pieces thanks to the separation guide that our digital team is planning together with the SafeCut and supporting my work because there is a huge simplification on the block management with the same piezoelectric tools, uh, creating a slot into the block and then finalizing with a diamond disc, not to lose too much bone. But this allowed us from coming in a very few minutes from one block to two pieces. And these two pieces, again, will be, since we know the shape, will be the next level of the guided Curie approach because knowing this, we can plan everything, not just the bone block we can check the bone block management, and we can do the block fixation. So diagnosis, first step for sure, defining how much bone is needed, perform the harvesting with a SafeCut plugin, and then dividing the block into two lamina with a YDF separation guide and the fixation guide that is coming to replicate the in the anatomy bone augmentation. So what is going to, which is the meaning of this, that we are going to work first of all on harvesting the bone. So a few minutes with the osteotomy performed, block is luxated, with a gentle work of the raspatorium. Look how the guide is sitting to the donor site. It's amazing the precision of the process. And then once we have done this, what we're going to do is to separate the block into two pieces thanks to the separation guide. And once this is done, we are going to work instead of working in the mouth, which is quite challenging to fix the buccal to the lingua, we work on a different replica. Different replica thanks to the fixation guide that allowed us to get the right relationship between the buccal and the lingual lamina and the right position when we are later on transfer this into the mouth, because we can fix the guide, fix the lamina, place one single screw in the mesial area, which is extremely easy screw to be placed, and then we can remove the guide, place a second screw, and fill the gap with autogenous bone particles. So the strategy is now to work the majority of the time outside the mouth and not inside the mouth. And this is the result post-op, everything exactly as planned. And this is the bone 4 months later, which is an amazing bone. At this stage, we are building up also the soft tissue so that we are changing completely the shape of this atrophic crest into a normal crest with the right soft tissue and the right bone anatomy without loosening the vestibule, which is the new strategy on the soft tissue that I developed with Giovanni Zucchelli in the last 4 years. And we published last year's in a modified coronal advanced flap, not to lose the vestibule position. And this is really changing everything because we need just to realign the mucogingival junction to obtain a great result and a great stability of the vertical bone augmentation. Because actually, this is the real target point. Uh, Digital means control, and control means predictability. So we plan everything in advance, and then we need just to go through the process, and which is every time following the same step. So the guided bone harvesting to collect the piece of bone with the great respect of the anatomical structure. And once this is done, we are going to work outside the mouth with the separation guide first, and then by fixing the two lamina in the deeper replica once has been scraped, and recreating the optimal relationship between the buccal and the lingual, not in the mouth, no flap, no bleeding, no strange position. And then we are going to transfer this into the mouth, fixing the first screw, taking out the guide, and place a second screw distally. So it's a very, very easy way of working to recreate the verticality that has been lost due to usually perimplantitis. And if I'm looking again, the pre-op, post-op, there is a great correspondence between the lamina position, the planned lamina position, and the given lamina position intrasurgically, thanks to the fixation guide. And 4 months later, we are easily placing implants in the vertical regenerated bone, taking care about the relining, taking care about the genetic envelope, and later on reconstructing the soft tissue. And this is the situation 3 years after the treatment, with a great, great bone stability and great success in the reestablishment of the vertical deficiency. So, and again, one view, latest case, diagnosis that is target related, which is not bone related anymore. Now we have prosto related to define what is supracrestal, what is bone defect. And then based on this, we go through the process of SafeCut, guide defining the surgical plan, so we know exactly which area we have to work, which depth, which direction. Anything that must be analyzed is analyzed. This is the separation guide. And the in anatomy augmentation, you see in the envelope and the fixation guide that allowed us to replicate this. So the surgery is starting after a digital process, and with all the tools in our hand, we can perform the bone augmentation from the retromolar area. This is a PMMA printed a guide with the tooth reference point. You see that the guide is going extremely easy in position, and we need just an osteosynthesis screw to stabilize the guide. And a few minutes later, again, the block is out with the correct shape, with the exact shape, with the desired shape. And then the block is going to be divided into two lamina thanks to the separation guide. And you see that everything is running exactly as planned. So it's like a route, and we follow the route, we follow the plan. Once has been divided, we work on the different replica that has been modified compared to the starting cases, smaller, with slot, specific slot to place the lamina to control everything, and stabilizing and fixing the two lamina together, and then transfer this into the mouth, giving the right position, three-dimensional position. Just two screws are placed in the mouth because we need just to stabilize the buccal lamina, because the lingual is already secure the lingual is already secured to the buccal outside the mouth. And then once we get the primary stability with the second screw on the distal area, we fill everything with autogenous bone particles, and we close the wound. And look again, pre-op, post-op, planning exactly respected during the surgery. And this is the situation 4 months later, the day we are placing the implants. Great bone obtained, placing the implants, and protecting this with a relining approach. Look, the bone 3.5 months later in this case. And then we have to correct the soft tissue, and we do a submerged CTG approach, which is another approach that I developed recently with Giovanni Zucchelli, where we are not doing a free graft anymore, but we do a connective tissue graft under a thin mucosa flap, by gaining even more stability of the vestibule and more high quality tissue in the area of the implants. So in this way, we are growing vertically on the crest, but on the supracrestal compartment area. So we're placing a connective tissue which is depithelialized and covered by the mucosa flap. So this is the situation 1 month after. So the day we are doing the implant second stage, and we are delivering immediately the temporary bridge. So this is the situation with the temporary bridge, and this is going to happen 8 months after the first bone augmentation. So as I was mentioning, the time to go to the loading is extremely short, even if it's a 7 millimeters vertical defect. And this is the timeline: 3 surgeries and 8 months from starting to loading. And this is the super nice quality of the soft tissue before and after. And you see, really, when you see look after the treatment, you may even not think or not believe that there was a vertical defect in that area. So the quality of the tissue is super, the vestibule is super, and is a combination, as I mentioned, of bone graft and soft tissue reconstruction that are bringing us to the optimal soft tissue and hard tissue scenario. And this is with the final restorations, comparing the STL pre-op, post-op, and you see how everything changed without loss of the vestibule and without a free graft to increase the vestibule depth, because actually the vestibule was reconstructed, but the crest was reconstructed but not lost, without moving the muscle actually on the top. And this is again the pre-op and final restoration. And this is 18 months after the bone augmentation, with a great fusion of the structure of the graft to the recipient side. So, and with this, I thank you a lot for being here at the beginning of the week. because it's every time a great effort to follow a lecture. And I'm very happy that you were here with me and with Francesca to sharing some protocols and some decision tree regarding bone augmentation. So thanks a lot. If there are some questions, I'm here obviously to try to give an answer. Um, and thanks again. Grazie.
Grazie a te, Luca. Thanks a lot to you because it's quite late also for you, and it's Monday, so
Well,
I'm
tomorrow is already Tuesday, so it's good.
yeah. I actually don't see any questions in the chat box, but I invite all the participants to make some. We still have a couple of minutes. Yeah, somebody texted Brian. Excellent lecture showing us how you have turned complex procedures into predictable workflows. Amazing, Dr. Luca. Do you have an email where we could request information to have your course in Costa Rica?
Yeah, thank you. Thank you very much, Brian. It's a great pleasure. I think that you're starting the day in Costa Rica right now. So, and no, I think that for all the information regarding the digital team work and all the courses, I think Francesca is the best person to write to because she knows everything regarding the work. I think that if you have any technical aspect regarding the digital workflow that we are following, you may also contact Carlo, which is our engineer in the team. So he may support you giving us technical answers because actually I'm not planning my cases myself because it's too much time consuming. I do the diagnosis and then there is a digital team working for that. And usually when we are outside Europe, it's very easy to share also planning or generally speaking guides because nowadays with the print machines that we have with the table printer we can just share STL file and then someone can print himself or ask its own lab to print for him. So it's nowadays I think that there is no barrier to share these type of technologies anymore.
Yeah, in the meantime, sorry, Luca, I just put this slide so if anyone is interested in knowing more about the digital services that you just explained, or even our courses, you can just take a picture to this slide and take our contact. It's my mobile number and also Carlos one. And that the QR code, you can find the program of our complete bone regeneration masterclass that we are going to have in Padova, not in Costa Rica, on next October with Luca, of course. And he will summarize the main concept that you have just seen with him tonight.
Yes, I saw that any of the screws are removed at the time of implant placement. Yeah, usually, yes, screws are removed the time of implant placement, the day of implant placement, and now part of the implant placement is also the soft tissue augmentation. So to reduce the overall surgical experience of the patient actually just on two surgeries. One is the bone augmentation, the second one is implant placement and the soft tissue grafting. So that really we are minimizing the number of surgeries needed to solve vertical critical size defect, but also minimizing the number of overall surgeries that are done on the patient. And now there was not the right environment to talk about the soft tissue strategies, but for sure if you have the chance to come to Padua, we are spending one entire day on the soft tissue management in bone augmentation, analyzing advantages and disadvantages of the choices that we may taken during the surgery or planning the surgery.
What
I
type of
use,
sutures do you use after the vertical grafting?
I use 50 PGA, 5 or 60 PGA, resolvable suture.
Hmm.
Thank you.
Raul is coming in October.
Oh, fantastic.
Ciao, Raul.
You will learn everything.
Okay,
Fantastic. So I think thanks, Francesca, again for managing everything. Thank you
pleasure.
for being with us. And I hope really to see you soon in Padua or one of our next webinar. I think that Francesca doesn't mention, but or you will mention that in some weeks you're going to
I
have the
was
chance to look at this webinar again. But don't forget that I'm doing the work of Francesca. Sorry, Francesca. You have to
okay. You can.
share this information.
Yeah, the recording will be available in the next weeks of this webinar. Thank you, Luca, for
No, but
anticipating.
also the oldest. I mean, we have
They are already on our free resources source of our website, so you can find all of them and also some clinical cases that you actually, Luca, did in your experience.
so thanks again. Thanks everybody, and enjoy the rest of the week.
Thank you, everyone. Have a good time ahead. Bye
Ciao.
bye.
Ciao, ciao.